You're on screen, Sharina. Can you hear me? You're muted. I can't hear you though.
Okay. Hi. Good evening. Is evening over there?
It is. It's 7:40 in the evening.
Okay. We're going to start this right now. Inshallah.
Inshallah, yeah.
Okay. Let me introduce you. Assalamualaikum dan selamat petang semua. Good evening to everyone. On behalf of Malaysian Orthopaedic Nurses Association, we would like to invite, we basically inviting Mr. Paul McLeish, which is, he's basically my lecturer. He's an orthopedic lecturer at University of Adelaide. So Paul, I'm going to give the platform to you now. So we're going to hear him for about probably half an hour, and then we'll probably ask questions. And to anyone that have question, you can even type if you don't want to, ask through the mic, or you can write it in Bahasa Malaysia. So probably I can translate it, inshallah. Okay, there you go, Paul.
Okay, thank you. Hopefully everyone can hear me. So good evening, Salamat Tenggahari. I don't know if I said that right, hopefully.
Yeah.
Might be close a little bit. So just remind everyone, if you can please put your computer or phone on mute for the Zoom session, that would be good. Hopefully, I will try and talk slowly because I have a strong Australian accent, so hopefully you can understand me. But if not, ask questions or ask some of the other people who may be able to interpret for you. Okay, I'm going to share my screen in a sec, so just bear with me for a second. Okay, so can you see that? So Sharina, can you see that? Can you just let me know? Shake your head. Or
yes,
nod your head.
It's clear. Yeah.
Yep. Okay, good.
Okay.
All right, I'm just opening up the chat box in case anyone asks me a question. So tonight I'm going to talk about hydration, and specifically for older patients in the orthopaedic setting. And we'll talk about why that's important and maybe why it's not done very well in some settings in Australia and around the world as well. So I guess we need to think about our patients, our older patients or our geriatric patients, and think about the care that they need based on the risks that they have. So people who have fragility fractures, who are older, so often that's something like a hip fracture or a lumbar spine fracture or a wrist fracture because of osteoporosis, they have unique needs and they also have unique risks as well. So we need to remember the fundamentals of care for them, as well as all the other things that go into being an orthopaedic nurse around cast care, neurovasculars, pain management, etc. So thinking about someone's hydration, their nutrition, their pain, their comfort, elimination is really important. So one element of that is the hydration. So what I want you to do is have a think about how do you assess the hydration status of your patients, or do you actually assess the hydration status of your patients? It's something that we should think about and reflect on, and I will talk a bit more about that as we go along. So one thing is to understand, is it actually a problem? If it's not, then that's fine. We don't need to change our practice. But if it is a problem, and maybe a hidden problem, then we need to think about how we go about assessing that risk of dehydration and how we can prevent it, which is better than trying to fix it or cure it. So ideally, if we can identify people at risk, then we can put in nursing care to stop those risks becoming bad. So how do we go about assessing the hydration status of our patients? It's very difficult to do. It's not the same as asking about someone's pain or looking at their wound. It's much more difficult to do than some of those things. So that's why maybe it's not done that well in some places. So we need to think to ourselves, do we know or do we check what someone's hydration status is? And if so, how do we actually go about doing that? And it's not an easy thing. So what is the evidence first? So the evidence in the literature suggests that adequate hydration is not well maintained in the acute care setting, especially in a place like a hospital after a fracture or something like that. Now, why is that the case? So sometimes it's because it's difficult to assess, and there's very limited tools available to assess the hydration status of someone. We may not give it enough priority, so we may undervalue the importance of making sure our patients are adequately hydrated. The signs may not be as overt or obvious. Their hydration status can change very quickly, and that makes it difficult to assess and check. And then sometimes keeping an eye or keeping track of someone's intake and their output can be difficult, especially if they are older, they have incontinence, they're not drinking much, they're vomiting, those sorts of things. And maybe we don't look at it on a regular basis, and maybe there's no resources or policy around that as well. So what are we measuring? Hydration status it changes very quickly, unfortunately, which makes it difficult. There are some assessment tools available to help do a formal hydration assessment, but they can be difficult and a little bit subjective. But what we need to think about is being aware of that as an important factor in our patients' care, documenting it, and that includes their input and their output, and then make sure we're maintaining very good fluid balance charts or documenting input and output. And if there is a difference between input and output, which is not expected, then we need to do something about that. So, for example, if a patient is not drinking very much, but they're passing a lot of urine, then we would be worried, are they becoming dehydrated, or is there something else going on that's causing that imbalance? The same goes if the patient's fasting and they're not getting an intravenous therapy, IVT, then there is a risk of them ending up dehydrated, especially if they're fasting for long periods of time, and especially if they're in a setting like in Malaysia that is warmer and more humid, and maybe they are sweating more than maybe someone in a nice air-conditioned room. We need to think about, does the patient complain of being thirsty? And if we think they are dehydrated, then we need to consider their intake. So is that oral fluids? Is it IVT, so intravenous therapy fluids? You can even use subcutaneous fluids. I don't know if anyone is used to administering subcutaneous fluids, which you can do very slowly, like 40 mils an hour via a needle that goes into the subcutaneous tissue with a normal intravenous, a bag of IV fluid. So there are some different options. So how do we tell if someone is dehydrated? Well, they may be thirsty, but the problem with that sign is that it's quite a late sign. So by the time someone complains of thirst, it is likely that they are quite dehydrated. So what we'd want to know is other signs that are much earlier, that give us an earlier indication of their dehydration. One of those things can be things like dry mouth or lips or tongue. All the surfaces of that are normally moist may have dried out, and that's a sign. The person may complain of a headache, or they might be tired. Their skin turgor might be bad. So if you look at me when I pinch my skin up, and you can all do this at home. Hang on, I'll go close. So if I pinch my skin up and let it go, it should go back flat relatively quickly. If someone is dehydrated, that skin will stay up like that after I let go. That's a very quick way of checking dehydration, and we call that skin turgor. The other thing, and this is probably one of the best ways of identifying dehydration, is looking at someone's urine. So what is the colour? What is the smell? And what sort of consistency or darkness is it? So if it is quite strong smelling and it's dark, then obviously that person has a level of dehydration, because they do not have enough fluid in their body to be able to make a lot of urine, and their urinary output will obviously drop. So there may be reduction in the amount of urine, and then there may be a darkening of the urine. And that's a really good sign that you should take notice of very early on. So whenever someone goes to the toilet, or if they pass urine, you should be checking what the colour and the amount of urine is as well. Is there any questions before I keep going? Hopefully people can understand me.
Yeah, Paul, so far so good. I think the pace that you're presenting is, is easy to catch up. And I think there's one question here. Just want to ask how we can get, it's about the e-certificate.
That's for the certificate.
I thought it's going to be.
I can't answer that.
Okay, let it go first. Probably if any question pop up, then I'll probably stop you.
Okay. No, that sounds good. So in terms of adequate fluid intake, so we obviously need to have fluids coming in. We should look at around 30 mils per kilogram per day. Now that's a very generic, very broad amount, and that will change depending on the person. If they're older, if they're younger, if they have got a fever, etc. If they've just been to surgery, if they have things like cardiac failure or congestive cardiac failure, then that would obviously be quite a lot different. Also, if they have acute or chronic renal failure, then that would need to change to meet whatever that condition is. So we need to be careful. So for a little old lady who's quite little, at least hopefully 1.5 litres a day. For someone who's a bit bigger, maybe over 2 litres. But if someone is drinking less than 1.5 litres per day, 1.5 litres, then that potentially puts them at risk. But we need to understand the situation that they are in. And that may be okay sometimes and maybe not okay other times. So what we need to think about is making sure someone who is at risk of dehydration has an active fluid balance chart running. So we're measuring their input and their output. Now that can be difficult if they're incontinent, or they go to the toilet without telling us, or their family takes them to the toilet, etc. But if we can, it's best to try and measure those things. That will give us better information to make a decision about what's happening. So if you are assessing the risk for someone, think about some of these following factors. So do they have the mucous membrane, so the lips, the tongue, skin, etc., are they dry? Do they have decreased restricted mobility? If someone is confined to bed, they have pain because of the fracture, they're very unlikely to be able to move around in the bed and get access to a bottle or a glass, even if it is close. It may not be close enough for them to reach and then to give themselves a drink. So we need to make sure that our patients have access, easy access to oral fluids. The other problem may be is they have a tremor or they don't have very good strength, so they can't hold a cup or a bottle. So for those patients, we need to look for alternatives. If someone is older, then they have more of a risk of dehydration. If they're having diuretics like furosemide or Lasix, then they may be at risk of dehydration. If they're confused, if they have diabetes, if they are constipated, if they are febrile or have a fever, then they are at risk of being dehydrated as well. If they have renal or kidney disease, or if there's other changes, or they have problems with their swallowing, that can obviously be a big risk factor for dehydration, and also their urine colour, which we've spoken about as well. Some of the other things, if someone is vomiting or they have diarrhea, so loose bowel actions, then obviously they are at risk of dehydration. If they have acute renal failure or injury, they're at risk. If some of their electrolytes are imbalanced, they are at risk. If they need IV fluids, intravenous fluids, or nasogastric or feed, then they are at risk. If they're fasting, all those things put them at risk. So we need to think about that when we're assessing the patients. Now, what is the risk of being dehydrated? So if our patients become dehydrated, then some of these things may occur. And some are relatively minor, but some can be quite serious. Now, the other problem is that some of these are also causes. So it ends up being a bit of a snowball. So some of the causes, like increased confusion, will lead to less oral intake. That will lead to dehydration. That will lead to worsening confusion. That will lead to less oral intake. And that just keeps getting worse and worse and worse to a point when they can get quite unwell. So we need to try and break that vicious cycle somewhere if we can do that and identify it. But the risks for dehydration are things like constipation, headaches, loss of appetite and decreased energy, which may affect their ability to be independent, to walk and do the activities that they need. There may be a rapid deterioration. They may become more confused and develop delirium. It can have an impact on electrolyte balances. So if someone becomes dehydrated enough, their sodium levels may change, potentially their potassium levels may change. If their potassium levels change enough, then they could develop things like cardiac symptoms and cardiac complications, as well as things like cramps. But those cardiac symptoms could be quite serious. If someone has become dehydrated enough, they may develop a hypovolemia, which is a decreased blood volume. And if that's bad enough and the person is old and maybe quite little, they may not have capacity to maintain their blood pressure. So via vasoconstriction and shutting down the peripherals. So that means that they may actually drop their blood pressure. And so when you go to stand them up or try and walk them, their blood pressure is so low that they actually lose consciousness and collapse, and they may hurt you and they may hurt themselves as well. So that's an important thing, especially in that post-operative period, is really a big risk for that. And that's mainly because they may be in pain, they may be nauseated after surgery, but also if they've just been to surgery, they will have lost blood in the surgical procedure, and therefore their blood volume will be reduced. It can impact on their renal function, so they can then develop acute renal problems. And at worst case, it can lead to shock and death as well. Often some older people are quite chronically dehydrated because they don't drink lots, and maybe that's because every time they drink then they feel like they have to go to the toilet, and if they have trouble with their walking and they maybe have some incontinence, then they're less likely to want to drink. So we need to consider that as well. The more someone is dehydrated, there is an increased risk of infection, especially with UTIs, urinary tract infections. And it can also have an impact on their cognitive function, so their awareness and neurological abilities. So knowing all that, some of the things, this is a project I was involved with at our local hospital a few years ago. We implemented a number of these activities, which some helped and some not so much. But these are the sorts of things that you can consider. And I will go through each of these individually. But it was really important to try and ensure that the nurses on those wards were looking at the hydration status of their patients and documenting that regularly. So we had red cups and jugs. So this was a visual clue for staff, but also visitors and families, that person who had that jug should try and drink regularly. So that's a physical prompting, a cue. And that led on from people who also had problems with nutrition, who had their meals brought out on a tray that was also red as well. We use things like jelly instead of water because the taste may be better, but also it's thicker. So if someone had problems with swallowing, they had some dysphagia, and they couldn't swallow water well, then the jelly was a good alternative. Some of the jellies did not need to be kept cold, so we didn't need to have a refrigerator to give them to the patients. This was probably one of the best things for the patients. So these charts were put in the patient's toilets. So every time they went to the toilet or the WC or whatever you call them in Malaysia, they would look at the colour of their urine and make a decision about where that was. Sorry, I'm not going to draw. So if it was in this region, that was okay. But if it was in this colour, when they looked in the toilet, then they should try and drink more as well. Someone said ice cream. That's an interesting point. I think we did think about that. I don't think the fluid amount is huge, as good as jelly, but is a good option anyway. And they're also getting a little bit of nutrition as well, which can be good for the right patients. So this was a good chart to have, and you can use this if need be. And this is an example in the Indonesian airport of the same sort of chart. So people who are flying and traveling will often get dehydrated. So this was in the toilets in Indonesia, and I also saw one in the toilets in Singapore once as well. So they're being used all over the world.
Don't think we have it here in Malaysia though.
You don't?
I myself haven't seen it before, so
No.
probably we need that.
I would. Yeah, no, it's a very simple tool, especially for the patients, which can be really useful.
Yeah, yeah.
The other thing we did was try to make sure that staff awareness and education was raised and reprioritising the importance of hydration. So making sure that the nurses were aware that it was important to keep our patients well hydrated. Otherwise, lots of other complications would occur. Probably the biggest reason for MET calls and medical emergency calls at my hospital was because of patients collapsing the first time they got up from bed after surgery. And that was often because of a low blood pressure, because of a low circulating blood volume, so hypovolemia, and that when the patient was flat in bed, their blood pressure was okay. When they sat up or stood up, the body compensated for a short period, but then was unable to maintain the blood pressure, and therefore they would drop their blood pressure and then they would collapse. So I'm just reading, there's a comment from Shanti. Fractured femur was unattended quite some time. Yes, that's definitely a big problem in a lot of countries, including Australia. Definitely, yeah. So someone who falls at home, if they live by themselves, they may be at home for many hours before they are discovered, and they will be seriously dehydrated, but also they will have problems with blood supply, they will have problems with pressure ulcers, their electrolytes will be deranged or imbalanced, and that's a really important. So that's why it's really important, especially early on in the admission, is to identify if someone is very dehydrated so that we can make sure that they get rehydrated appropriately. Now, having said that, it's very important that we don't rehydrate someone too quickly, especially if they are older and have a form of cardiac failure, because there is a risk that we can run an IVT very quickly, and because that person's cardiac failure and their renal function maybe is not very good, that we can end up pushing them into pulmonary edema. So it's important to make sure we do that relatively slowly for the right people as well. That's the important consideration. This is from the UK, so from England, the NHS. So this is where we got the idea for the red jugs. And this is a process. This is a program they had many years ago, which was designed to make sure people drank, were hydrated enough. So you can look up the NHS with this program.
Mm-hmm.
That's the National Health Service. So some of the things we didn't think about initially for this project was including people from speech pathology, especially for patients who had trouble swallowing. If they'd had a stroke or they already had some swallowing problems. Trying to make sure we include all the other staff who are responsible for the meals, so delivery of the meals and the fluids is important as well. And thinking about the costs. So if we use lots of jelly, that jelly costs more than water. Water is relatively cheap and better, but if you use lots of jelly, then it costs more money. So that can be difficult as well. But really the secret is just making sure that at least we're checking to make sure that we're assessing the hydration status of our patients, especially the older patients, because they're either already dehydrated, before they fell and before they sustained a fracture. They're either dehydrated because they have been immobile for a while, or they may have actually fallen because they are dehydrated. So if they dropped their blood pressure and they became dizzy, they took their normal antihypertensive medications, that may have caused the fall. So that can be an important element of our assessment when we're looking and caring for patients who are older who have orthopaedic injuries. And that's it. That's all.
Oh, okay. Basically, does anyone have a question here? We have like nearly 100 participants. Sesiapa ada soalan?
It's a very good turnout.
Yeah. Sesiapa ada soalan boleh tanya ya. And then saya boleh translate kan kalau yang mana nak saya bantu. Kalau tidak boleh type terus dalam bahasa Inggeris. Encik Anwar ada soalan? Tak ada. Paul, the thing is, what I find about your study, which we don't have here, is about, you know, when you said the small act, such as putting a red cup, would actually make the staff alert about, you know, this is the patient that you need to look into. The intervention is very small, but I can actually see that, you know, the impact is going to be huge, you know, and we don't do it there. And it kind of like, you know, give me an idea that, you know, that red cup would actually help a lot.
Yeah, it is difficult because we have lots of other things that we need to do for our patients.
Yeah.
And sometimes they're very sick and our attention gets drawn to those things, which makes sense.
Yeah.
But sometimes the little things can actually be very good in preventing other complications.
Yeah.
So even just making sure that wherever the cup and the jug is put is within the reach of the person. So, you know, you don't have the jug down the other end of the bed or wherever.
Yeah.
Or if they're shaky or they can't grip something, making you have a little thing at the top where they can pour it in. Those little things can help.
True. And what being in the clinical side here, what I find is that, you know, the ratio of nurses to patient here are like massive. Probably one nurses will be taking care of like 8 to 12 patients. That kind of like, you know, the red cup probably going to help because, you know, the attention that the nurses give towards especially geriatric patient with, you know, dehydration issues, you know, this red cup does would help, I hope. And part of it, what we do here is that usually the doctor will order for input and output chart. And whatever glass that we have, like if we have a mug, we kind of like estimate it, like, you know, one mug is going to be like 250. So during student time, we actually like, you know, put a chart and we really count it. And but nowadays what we do is like, okay, one mug is probably going to be like 200, 250. We're going to make sure that, you know, they finish this. And we have a regime. If the doctor orders like, you know, you need to finish this within 1.5 mil for this patient, then we break up into AM shift, PM shift, and online.
Okay.
So those kind of regime, what we do it here, I mean, probably from the private sector, I'm not sure because we have like hundreds of participants, probably some of it from government trained nurses, but usually the government trained nurses go through the same, you know, level of education. All what being taught to us are basically the same. We have an input-output chart, and if we have a geriatric patient, usually the doctor will ask us to do, you know, strictly charting, and then we have this regime. At the end of the session of our work, and we need to close it. It's the same as in RA, I think, you know, in Royal Adelaide Hospital, what I
Do
see,
a subtotal.
yeah, you already have that.
Yeah.
Mhm.
From my point of view, that's very important. But like anything in nursing, there's not one thing that works the best. So you push the fluids as best you can. So try and encourage the patient to drink. But
Mhm.
at the same time, you're seeing what is their blood pressure,
Yeah.
what is their skin turgor,
Mhm.
what is the color of their urine, what is the smell of their urine. All that information is coming together to make a decision about, are we giving this person enough fluids?
Yeah.
No matter what the chart says, if the chart is up or down, if
Mhm.
their urine is a good color, their skin turgor is good, their blood pressure is good, even when they're standing, not just lying, that's
Yeah.
important, then, okay, that's good.
Mhm.
Less likely to be a problem. Yeah. So
Yeah.
all that information feeds in to make a decision about the person.
Okay. And again, about the subcutaneous fluid.
Hmm.
I mean, this is the first time I'm hearing it, so.
So it's not used very commonly, but often if someone is a little bit dehydrated, they have a little bit of trouble with oral fluids,
Mhm.
like they may be confused and resistive.
Yeah.
And maybe they keep pulling their cannula out of their veins in their
Yeah.
arms.
Yeah.
You can put a needle under often in their abdomen,
Mhm.
under the skin, and then run an intravenous therapy into that at 40 mils per hour.
40 mils per hour. Okay.
Yeah, not any faster, because the body will slowly absorb that liquid, but not at a
Okay.
faster rate.
Okay.
So it's called, it's got a long name in English. It's called hypodermoclysis. So it just means
Hypodermal. Okay, I probably.
dermo, so under the skin
Okay.
infusion. Yeah. But that can be useful, and it's relatively easy because you can just set it up with a pump or even just a normal.
Yeah, infusion pump. Yeah, we can't be standing
Yeah.
there and doing it. So probably
No.
infusion pump will be the right thing to use. But it's the first time I'm hearing it. So yeah. Ada soalan lagi tak? Is there any question that you want to ask, Paul? Everybody is like.
It's a very. Oh, that's right. They're all thinking. It's always embarrassing to ask a question if you think, oh no, everyone. And there's lots of people to watch. There's 100 people.
Yeah, I mean,
Very
yeah.
good effort. Very good.
Okay.
It's well done, everyone.
Okay. And Paul, probably can you introduce yourself? Part of it, we might have some medical assistant, MA, we call it MA. They are basically like nurses, but not fully trained as nurse. And we also have a group of male nurses here. So probably can you give like some, you are from male nurse background, because most of the nurses here in Malaysia are like female. So probably, the journey of you from being a nurse and then joining and being a lecturer and being a male in this field. I mean, can you share with us some of your, journey throughout?
Yeah. So I finished high school in 1985.
Okay.
And I worked in a bank. Very boring job. I did not like it. Then I travelled overseas for 4 months, and I came back and I did lots of different jobs. I made clothes dryers, I made soft drinks, I chopped firewood.
Wow.
All sorts. And then I decided I wanted to work with people. Oh, crazy. No. And so I became a nurse. And I think I became a nurse because when I was very young, my parents went to Papua New Guinea as missionaries, and they helped run the local hospital. So I was always at the hospital with the doctors and the nurses. So maybe that rubbed off on me. I'm not sure. So I started my nursing training in 1989, a long time ago.
Okay.
At the hospital. So I was hospital trained, which was a lot of fun. I had lots of fun times. And I gradually became more senior in the hospital. And then I started doing some other studies. So I did a Bachelor of Nursing, I did a graduate diploma of nursing. I did a master of nursing, and now I'm doing a PhD of nursing.
Yeah.
But that is over a period of maybe 15 years. So very slow. But initially I was very practically based. Like I liked the idea of the practical
Side
nature
of
of nursing.
nursing. Yeah.
Yeah, and especially in orthopedics, because in those days there was a lots of traction and plasters. It was very nuts and bolts. Yeah, a little bit more male maybe.
Yeah.
So in orthopedics there was lots more males than in general nursing.
Okay.
And maybe because of it was slightly heavier work, maybe, I don't know, or to be a bit stronger.
Yeah.
But when I trained at the hospital, in my group there were 30 people, 30 nurses or students, and there were 6 male nurses out of 30. So it was actually quite high for those days.
Okay.
Then for a little while the male numbers went down, and now they've come back up a little bit. Australia still sees nursing as a very female profession, but there's lots of male nurses because it's a good, it's an interesting profession. There's lots of challenges. There's lots of opportunities.
Yeah.
So I and my current students, there's lots of male nurses again, so it's starting to come back a little bit.
Yeah.
The main thing I would say about being a nurse, and what for me, was to be curious. Do you understand the word curious?
Yeah. Sikap ingin tahu. Yeah.
Yeah. So why is something happening? Why do we do something a certain way? How could I do this differently? And that's all wrapped up in the reflection.
True.
That is absolutely core part of nursing. Think about what am I doing? Why am I doing it? How is it working? How have I seen someone else do something slightly differently that worked better or worked not better, much worse? And then letting that inform my decisions and my practice for the future.
True.
That's the absolute core element of what nursing is.
Keep asking why, it's the same
Always.
thing. Yeah, always. Because I think this is what we do also at the clinical area. You need to rationalize each of the things that you do to the patient. Each of the things that you give to the patient, you serve the patient. Why are you doing it? And if you keep on asking that, and then I believe it eventually you will develop this way of you kind of like have a active critical thinking way of doing things, because you keep on asking why you're doing it. In orthopedic ward, because there's a lot of, sometimes in general people might think working in orthopedic ward is kind of like, it's not the same as ICU, but we still have a specialty that we need to preserve. And I hope that is why, from Malaysian Orthopaedic Nurses Association, this is what we try to bring back, the legacy of orthopedic nursing specialty, so that everybody understand the importance of this specialty to the older patient, to the patient in general, all the patient with musculoskeletal disorder. We don't want to be known as, like a general nurse. We want to be known as a nurse with orthopedic specialty, and we are specialized. So I hope, we have 100 people here. So you will join Malaysian Orthopaedic Nurses Association. I'm promoting now.
Yeah, good, definitely.
So
the problem is like you're saying, we learn to have that critical thinking, but what happens is over time it almost becomes subconscious. So we have learned to do it, and we learn to do it very well, but we have trouble identifying it. And then if we can't identify it, we can't say it. And if we can't say it, we have trouble teaching it. And if we can't say it and teach it, it's hard to justify what we do. So if we can stop and think and articulate or to say what we do and what's special, what the key skills and knowledge are around being an orthopaedic nurse, then we can make that obvious to other people.
Yeah.
So I use the example, if you watch a nurse, a patient that's in traction in a bed, in pain, they're incontinent, their traction's all over the place. If you watch 3 nurses go in there, they do a whole bunch of things, and then they walk away, and that patient is all fixed.
Yeah.
Yeah. To look at that looks easy. That's straightforward. But what's going on in all those 3 nurses' head?
That's a principle.
This subconscious understanding and skills and knowledge, and experience and principles that make that practice very, very efficient and looks easy.
Yeah. So this is what we are trying to bring back, and we're trying to motivate all these Malaysian nurses and also all the medical assistants, if you're out there, so that we can work together and learn from each other and bring back this kind of nature of working, the essence of orthopedic nursing. When I was during the clinical part of my days in Royal Adelaide Hospital, I can see the nurses in orthopedic ward, even though they are male nurses, the way they are teaching me, Sharina, you have to wipe behind the ears, the way how you need to keep it clean. And I'm like, okay, this is, they go into in-depth of, reasoning of why we're doing it. And, remembering back how Gavin teach me how to put the alignment of the leg and why are we doing it? Why are we using this traction? We need to justify that. And it is not only, the doctor's job. It is also our job to understand what we are doing, because we are much more closer to the patients.
You're the only ones there 24 hours a day. Yeah. So if someone is dehydrated, you should know before the doctor does that they need to have an in and out chart, and that maybe we need to start an IVT. Yeah. Definitely.
So before I close, is there any question? Ada apa-apa soalan yang nak ditanya? Is there any question? Everybody is saying thank you. Okay, to the one that any video or audio that you can't hear, we are recording this, so probably we will put it in YouTube, right? And then you can access this. So masih ada harapan untuk tengok balik, insyaAllah. And Paul, you want to say anything about the Enzona conference? Probably, anybody interested?
The Enzona conference will be in Adelaide this year in October. I'm not 100% sure what the option will be for international people. I think the plan is to offer either the entire conference or parts of it online. So I doubt very much by that time you will be able to get into Australia.
No, I don't think so. I don't think so.
But we will let you know what the options are for online access, and we can maybe help, if there's fees and stuff like that, we can help. But it's a very useful thing to be involved with, because you will get exposed to lots of other nurses, often from all around the world, doing different things in orthopedic nursing that may be applicable to your practice. So that that can be good.
So the Australian New Zealand Orthopaedic Nurses Conference is going to be in October. We will put all the updates in the Mona website, in Facebook page. You probably can look it out, and inshallah we'll we will have a lot of this kind of like education session, inshallah. And I hope all the lecturers and nurse practitioners from Enzona will keep on supporting us. Thank you.
We're very happy to. So you organise, if there are topics that are very, useful, let us know, and we can make sure we get someone to present. That's a pleasure, and that's really useful. And it's also, it is very useful for us as well to hear what's happening in other places. So,
Yeah.
and Sharina, I see you've got your university
Yes.
thing on there. That's
Yeah,
good.
I'm like, I'm really proud of this, you know.
Your
I'm like,
badge.
no, I've
Yeah,
studied for 2 years. And you're my teacher.
No, well done.
So thank you very much. It's
No,
been like
that's right. My
nearly more
pleasure.
than 4 years it's here. So I'm
know.
I'm wearing it proudly.
And your publication that you did from your masters has been cited, I think,
Yeah,
maybe 4 times, I think now,
yeah.
from other people's publications. So
Alhamdulillah.
that's really good.
Yeah. So thank you very much, Paul. We already taken your time about 1 hour, I think.
Oh, that's all right.
It's
getting a little bit dark outside.
Yeah. So
that's all right. It's hot today, so it's nice now. So
thank you very much. And
thank you, everyone.
this is our first attempt, so probably we'll do better next time. Thank you.
That's good. Well done.
Terima
Thank
kasih
you, everyone.
semua. Thank you. Bye-bye. Bye. Paul, you are the, you have to go first.
I have to go first.
Yeah,
all
because
right.
You are our guest.
Okay.
You are our guest.
I'll leave. It's like I'm leaving the stage. Yes. Okay.
I can't leave.
All right. See you all.
Okay. Thank you. Terima kasih semua. Please join Malaysian Orthopaedic Nurses Association, and we will put up if there's more education session. Thank you very much. Bye.
மறுபடியும் தனிங்க